And my daughter, for instance, even had to undergo surgery, which she wasn't supposed to undergo. After she came out of theater, it was found that actually she shouldn't have gone to theater, but the damage was already done. And this was before the diagnosis. But now, a lot of hospitals are knowing how to treat sickle cell. They are knowing how to suspect a child who is showing certain symptoms, and things are becoming easier and better. There's also long hospital stays. There are some children that would stay in hospital for months, and with sickle cell, any internal organ can actually get affected. And we have a lot of children under 5 years old having strokes. So, with a stroke, the child is going to stay in hospital longer, and also other complications. And also we have emergency admissions at night. Most of the times, the child would be fine or pretend to be fine during the day. And sometimes, like my daughter would tell me, she would say, I started feeling bad during the day, but I thought it would pass. So I did this. I tried to do this. And then at night, she becomes serious. Sometimes she would tell me, it's too much of me going back and forth to the hospital. So I didn't want to trouble you. But the problem comes at night, and it has to be an emergency. And then we also have, a lot of caregivers, even warriors themselves, the adults especially, they get irritated with explaining the patient's history repeatedly to new medical teams. Even the same hospital that you go to, when you go there and you find another doctor, you have to explain the history, which is okay. But that is something which is like, it's not pleasant for someone living with a chronic condition. But yes, we understand that history is important to any doctor who comes through. And then we also have caregivers who carry big files all the time to be ready for emergencies. As I said, when you go to UTH, and because an emergency may happen at any time, you need to have your file with you. You keep it either in your car, or you keep it somewhere at home where it will be easier to pick. So these files are not thick files. I mean, they are not slim. They are thick files. My daughter is only 17. She's got about 6 or 7 thick files. Some from UTH, from Levi Mwanawasa, and other hospitals, including the hospitals that we've been taking her to in India. And then we also have lack of emotional support. In the medical field itself, we've got lack of emotional support. And also we tend to have lack of emotional support from our families and friends, because people think that you are a caregiver, you are used to hospital, you are okay. And because you see me smile, you see me talk, you think I'm able to carry this burden. You do not know that every time I take my child to the hospital, the emotions are fresh and they are new. And why they get so painful is because when your child is sick, you don't know how that sickness is going to end up. As I said, sickle cell can damage internal organs. So you are not sure whether your child will come out okay or not. And then we also have people around the family with sickle cell being left to navigate on their own. They, as I said, you think that you are strong enough, you are able to carry this burden. So these are the things that actually that we face as caregivers, as warriors, that And then my third point is traveling for specialist care. So under this point, many African countries have got less specialized personnel. You find that you go to a big hospital and you are treated by a pediatrician if your child is young. The pediatrician is going to treat the child with sickle cell. The pediatrician is going to find the problem and say, okay, you've got a problem with kidneys. And okay, that's just an example. I know we've got the renal department, but you may find that the same doctor is treating so many complications. And with sickle cell, we need specialized personnel. When I took my child to India, I was shocked to find even the little parts of the body that they are specialized. There's a specialty, there's a doctor, there's a department that will go to look after that. So in Africa, we lack that. And then families have to travel to other cities or countries for treatment. Just here in Zambia, people in the rural part of Zambia can't get the care that we get from UTH. Someone from Solwezi won't get the same care that I get from UTH. And also within Lusaka, people from maybe, let me say, Chipata compound may not get the same care of treatment that Matero level 1 is getting. So we've got a lack on that. And then we also have a follow-up on return, which is discontinued or delayed. And the discontinuity mostly is because maybe a caregiver doesn't have transport money to travel long distances to go for a follow-up. And also sometimes the delay is because they can't, like maybe you need to go to see a specialized person, and you can't get the date which is like close enough, and then because of too many people that need to see this specialized personnel, so you end up getting delays in that, and that actually makes the condition to also worsen. And then sometimes it may also be difficult to access hematologists because we don't have enough hematologists in Zambia. I'm talking about Zambia, but I know that even other countries in Africa are facing the same situation, because I've interacted with a lot of other countries, and this is what everyone from other African countries talk about. And then we also have, the cost of travel may be so high, and most of the caregivers fail to keep their jobs because of the hospital life, in and out of hospital. So most of them won't work. Most of them won't do business as they want to do. My fourth one is a burden on families. It brings financial strain. It brings mental exhaustion, parents missing work, siblings affected emotionally, because a little child should have a healthy life. But a sibling who doesn't have sickle cell, seeing their sibling in and out of hospital actually affects them emotionally, and we don't actually pay attention to the siblings. Constant fear during crisis. When your child is in a crisis, you don't know what next is going to happen. Fundraising all the time, because you don't have enough money. You need to fundraise all the time. Every time your child is in hospital, you don't have money, and you start calling people to help you with money. That is a burden. Paying for tests. Certain tests are not covered by insurance, and you have to pay from your pocket. And then caregivers sleeping in hospitals for weeks or for months. And our hospitals are so, they don't have space for a caregiver to have a bed. So caregivers are given a chair. And you can imagine a caregiver is in hospital for months or for weeks, and all where she sleeps is just on a chair. So that is also a burden. And then it's an emotional toll after repeated admissions. My fifth point is why early diagnosis alone is not enough. Because after you are diagnosed with a condition or with sickle cell, you need continuous care. And usually we lack that in Africa. Medication may not be available. Education for families. Some families do not even know why you have to take this medicine. And some families want to get the grandma's tails. You get an egg and put it with Coca-Cola to bring blood. But you don't know why a sickle cell child is anemic. So you do wrong things because of lack of education. Mental health support, specialized referral pathways. We need newborn screening. Yes, UTH and a few hospitals now in Zambia has started newborn screening, but we need newborn screening in all the parts of our country and also in Africa. And then the follow-up system should be improved, and then better transition from pediatric to adult care. As I said, my daughter is 17. She's supposed to now start going to adult care. And this is a child at 17 going to adult care. And, you know, adult care, the care is different because they treat you like an adult. So that is also a problem that we have. And then in closing, or call to action, I would say we need better systems, and better systems are possible in Africa. African patients deserve coordinated care, collaboration between government, the hospitals, NGOs, and digital health platform matters. Thank you so much.
Wow, Changala, thank you so much for laying that foundation. What an inspiring story in terms of what you're doing, not just for your own family, but for the greater community that's been afflicted by sickle cell. So with that foundation, I'd like to introduce our second important voice in the room. She brings with her the clinical lens in terms of what we're discussing here today, the perspective of a doctor who has sat at the front line of some of Africa's most demanding health crises, who has also spent her career asking the hardest questions in health systems, not just how do we treat patients in front of us, but how do we build a system that ensures the patient in front of us is never failed by the infrastructure around them. This is Dr. Salome Chirwa. She holds a medical degree, a bachelor in medicine and a bachelor in surgery, and is a candidate for her Master of Public Health, a medical doctor based in Malawi with experience spanning clinical medicine, health systems, strengthening, and emergency preparedness and responses. She currently practices at the Lilongwe Adventist Hospital, working at the intersection of frontline clinical care, and the systematic questions that she'll be bringing are basically attributed to whether care reaches the people who need it most. She has contributed to response efforts for cholera, COVID-19, polio outbreaks, working with government, academics, development partners, and health system initiatives across the continent. Her professional focus spans health systems, resilience, health innovation, emergency preparedness, climate and health, and the strengthening care delivery in low-resource environments. She's the CEO and co-founder of NISI Health Intelligence, a company focused on advancing resilient, adaptive, and innovative health systems solutions across Malawi and beyond. She's actively involved in initiatives that promote women empowerment, mental health awareness, and a mentorship program for young medical professionals. Please help me welcome Dr. Salome Chirwa, all the way from Malawi. Doc, you're in the room. Please, the floor is yours.
Thank you so much, Sydney. Let me share my slides. I hope I'm audible enough.
Yes, you are. Please go ahead.
right. Okay, I hope we can see them. Just give me a yes.
Yes, we can.
All right, thank you so much. The executives of AfriPharm Health and My One Health, honored guests, fellow healthcare professionals, ladies and gentlemen, all protocols observed, good afternoon from Lilongwe, Malawi. It is a pleasure to be with you this afternoon. And also thank you to Mwanza Changala for the powerful talk, highlighting the burden on patients and families with seeking care. We don't talk about sickle cell disease enough, and it is inspiring that she is an advocate and pioneer of this complex disease. A round of applause for you again. So, this afternoon, I'll begin with a story. It is midnight in Enukwedi, rural Malawi. A woman is in obstructed labor. She traveled from a remote village seeking care at the community hospital. The diagnosis was clear. She needed urgent surgical intervention. But that night, medicine was not the problem. The facility had no electricity. The generator had no fuel. The ambulance was away transporting another patient to the district hospital. The nearest fuel station was miles away. And so, a medical emergency became a systems emergency. That night taught me a lesson I have never forgotten. Patients don't die because medicine doesn't exist. Patients often suffer because the pathway to treatment is fragmented. Most people think healthcare begins when a doctor sees a patient. It doesn't. Healthcare begins when someone realizes they need help. From that moment, a journey begins. From home to clinic, from clinic to hospital. From hospital, they are referred for higher care for treatment, and then from there, they're sent home for recovery. At every stage, the system either helps them move forward or creates another barrier. In many parts of Africa, patients are not fighting illness. They are fighting they are fighting distance. They are fighting delays, fragmented referral systems, transportation barriers, information gaps. The journey itself becomes part of the disease. I learned this lesson again during cholera response work. A 2-year-old child was referred with severe cholera, severely dehydrated, low blood glucose, developing acute kidney injury. The child needed higher level care urgently, yet treatment centers were overwhelmed. Isolation wards were full. Healthcare workers were overstretched. Resources were under pressure. Again, the challenge was not diagnosis. The challenge was movement. Could the patient reach the right care quickly enough? Could the system absorb one more critically ill child? Could the next facility receive them? Emergencies and outbreaks, cholera, COVID-19, Ebola, floods, they don't just expose what is already fragile. They reveal the cracks we often don't see during normal operations. When people hear these stories, they think this is only about Malawi or poor countries. It isn't. Across Africa, millions of patients encounter similar barriers. A critically ill diabetic patient in Malawi, a child in need of immunization in Zambia, a mother suffering from HIV and TB in Kenya, a cervical cancer patient in Ghana, a sickle cell patient in South Africa. Different diseases, same challenge. The right treatment may exist, however, the path through which it does not. For decades, we have focused on healthcare facilities, building hospitals, training clinicians, buying equipment. These investments matter, but a question remains. What happens when the care a patient needs is not available where they are? Where do they go? Who guides them? Who coordinates their transfer? Who ensures continuity of care? Who supports them when they return home? This is where many systems begin to break down. So who pays the highest price? The burden is not equally shared. The most affected people are often women, children, the elderly, rural communities, people living with chronic conditions, and populations affected by disasters and outbreaks. The people with the fewest resources often face the greatest barriers to accessing care. And every delay widens existing inequities. So why does this matter? As healthcare professionals, we often focus on treatment, but patients experience healthcare differently. Patients experience healthcare as a journey through people, through facilities, through systems, through countries, and through hope. Every broken connection increases a risk. Every successful connection improves outcomes. And that brings us to the most important question. What would happen if no patient had to navigate that journey alone? What would happen if referral pathways were coordinated? If expertise could cross borders? If continuity of care existed before, during, and after treatment? What would happen if healthcare systems were connected rather than isolated? Because the future of healthcare is not only about delivering treatment. It is about delivering pathways that make it easier for patients to access treatment. And that is why today's conversation is so important. Thank you.
Dr. Shiva, thank you so much for that insightful presentation. As always, the way we do this is to first lay the foundation of what our featured guests will basically be coming in. And I'm happy today to present our partner in healthcare crime, as we may call it, but basically delivering on what the two speakers have basically laid out in terms of the challenge, but also on principle in terms of what needs to be done to arrive at equity, at continuity, at the same time at the quality of health in our continent. I'd like to introduce our two featured guests today. They are from My One Health. The first speaker will be Andrew Muti Johnson. Our first featured guest, as always, is someone, if you heard what Mwanza set out in terms of what she's doing in the communities and what every doctor can learn or do from what Dr. Salome had actually laid out. The commercial and partnership architecture that makes global care access real at the market level lies a lot with partnership and collaboration. I'd like to take this opportunity to introduce you to Andrew Jason. He's a senior referral partner manager at My One Health. He's in charge of strategic partnerships and business development in terms of as a leader with over 20 years of experience driving market expansion, enterprise partnerships across Africa and other foreign markets. He currently leads the development of My One Health Referral Partner Network across Africa, working closely with health insurers, corporates, NGOs, and healthcare providers to expand access to specialized healthcare services. With all of that introduction, you now understand why the first two had to go first. He previously spearheaded My One Health Insurance Partnerships verticals and has held senior commercial leadership roles across health tech, branding, and communication. Andrew understands what it takes to build referral infrastructure that works at the ground level across diverse African markets, diverse patient profiles, and diverse institutional relationships. He's here today to speak on how the My One Health and AfriPharm Health partnership creates the structured pathway that Mwanza's families and Dr. Salome's patients, or shall we call them warriors, have never had, and what it takes to activate it at a scale across all the African markets. Please help me welcome Andrew Jason. Thank you so much. Andrew, the floor is yours.
Thank you very much, Sydney. Thank you for the lovely introduction. And indeed, you have actually set the stage to this conversation and also to the AfriPharm Health and My One Health partnership. It was really pleasant listening to Mwanza Changala and Dr. Salome Chirwa. A lot of what Mwanza actually spoke about, we actually relate to it. And I must say that I want to give a shout out to all the caregivers in Malawi, in Zambia, and worldwide. They do a fantastic job. I'll try as much as possible not to take too much time. Let me share my screen. Kindly hold on. Can you see my screen?
Andrew, you have the ball. Take it away. We can see your screen.
All right, perfect. Thank you once again, Sydney. Good afternoon, everyone. As Sydney has mentioned, my name is Andrew Mwiti Jason. I'm the Senior Referral Partner Manager for My One Health. Over the next 9 minutes or so, probably shorter, I want to give you a clear picture of what My One Health does, how our referral pathway works from first contact to treatment, and what this partnership with AfriPharm Health means for the people and organizations you represent. Let me start with how we work with every patient. My One Health operates across 4 pillars. We match, connecting a patient to the right specialist facility for the specific condition and treatment needed. We coordinate, managing clinical handover from the moment of referral through treatment and follow-up. We support, looking after the patient and the family across travel, logistics, and the full care experience in country. And we return, bringing the patient home to their local care network with fully continuity of records and aftercare. And that's exactly where AfriPharm also comes in. These 4 pillars are not sequential. They run in parallel. The patient is never left without someone responsible for their journey. Let me explain how matching actually works. Every referral begins with case intake. Our patient support team gathers medical history, imaging, and clinical reports. We then carry out clinical triage, reviewing the conditions, complexity, urgency, and treatment options against specialist criteria. From there, we shortlist facilities, not on availability, but on specialty depth, accreditation, technology, and patient volumes. What are we screening for, you may ask? And the simple answer is clinical fit, treatment availability, JCI accreditation and equivalence, patient outcomes, cost and timeline, and language, culture, and logistics. And this is because getting those wrong undermines everything else. The match is not the easiest option. It is the right one. Once a match is confirmed, coordination begins. The process runs across 6 stages, from referral and records, through specialist consult and treatment planning, into treatment and monitoring, post-treatment review, and finally follow-up and handover. 2 things run in parallel across all of this. First, active case management. One person is a single point of contact for the case. They escalate fast and keep every party, that's the referring clinician, the hospital team, and the patient's family, aligned at all times. And at My One Health, we have a dedicated patient support team. Second, outbound logistics. Once a match is confirmed, My One Health takes on everything the patient and the family needs to actually get there. We manage the medical visa application, flight coordination, hotel accommodation, airport transfers on both ends, and in-destination support throughout the stay. This also includes translation services where needed. The patient does not arrange any of this. We do. Once again, one case manager, one handover, no gaps between teams, and no logistics burden on the patient. So what does this partnership mean for the people here in this webinar? For patients, a structured pathway to specialist care, end-to-end, one team managing every step, no gap between treatment abroad and care at home. For insurers, a trusted global referral network with over 20 insurance partnerships already active across Africa, transparent cost estimates and pre-approvals, and clinical outcomes tracked and reported. For healthcare providers, a seamless referral mechanism for the cases that fall outside local treatment capacity. And of course, full records continuity when the patient returns. Together with our partner, AfriPharm Health, we cover the entire arc. AfriPharm Health holds a patient before departure and after return. My One Health coordinates everything in between. To be honest, I sometimes ask myself why this partnership did not start sooner. It's at this point I will hand over to my colleague Eve Wilson, who leads our global hospital network, and will walk you through exactly how patients are matched and supported from arrival through to their return home. But I'm sure that Sydney would want to introduce her because he's got a gift at that. Thank you very much.
Thanks, thanks, Andrew. You are going to do an injustice if you just passed on the baton to her. Ladies and gentlemen in the call, Eve Wilson is basically in charge she's the heart, she brings the whole experience, the heart of operation of My One Health. If Andrew builds a pathway that connects patients, Eve is the person who ensures that whatever happens in between and what has been promised at the referral point is delivered to the hospital. Eve Wilson is a client success and healthcare network manager at My One Health. She leads My One Health's global hospital partner network. That's over 350 JCI accredited hospitals across six continents. She's responsible for ensuring that referred patients are matched to the right specialist facility and that the clinical coordination process runs seamlessly from referral through to treatment paths. Eve also drives My One Health's market access strategy, identifying new treatment destinations. So if they're out there, she'll find them for you. She's here today basically to speak what end-to-end clinical coordination looks like. Please help me welcome Eve. Eve, take it away.
Thank you so much, Sydney, for the comprehensive introduction. Good morning, good afternoon, everyone on the call from wherever that you're joining us. As I commence, I take this opportunity to thank, as I begin, I'm taking the opportunity to acknowledge Mwanza and Dr. Salome for the comprehensive introduction that they've shared, and also highlighting the gaps that we're currently experiencing in Africa in regards to medical treatment, especially when it comes to specialized healthcare treatment. From the aspect of misdiagnosis, the lack of coordination when treatment is not available locally, where does one get to go in for that treatment? The lack of emotional support that the caregivers and parents require when they walk that journey, and also at the point of returning back home, there is no continuity of care, and there is that gap where the local doctor treating you back home does not understand what care was provided overseas and what they need to continue doing to ensure that you're healthy and the treatment that was given overseas proceeds to take up as required. So my colleague Andrew has given a comprehensive overview of who we are and what we do. And sorry, I just noticed I didn't introduce myself. Sorry for that. My name is Eve Wilson. I am in charge of the healthcare network for My One Health. And basically our role is to be able to transform how patients access specialized healthcare services by identifying what are the gaps that patients are facing, how do we bridge that gap for them, and which hospitals through the different destinations that we're reaching out to are able to provide that treatment for various people at different price points. So my colleague Andrew will be sharing the screen on my behalf as I take you through the patient journey. And for us, basically, the patient journey commences at the point of when a family or a patient is looking for treatment. They could probably be receiving treatment locally, but they are experiencing that aspect of dissatisfaction with the results that they are getting. And at times, you don't have to wait to the point where you're feeling the treatment that you're getting locally is not working, by just being able to get a second opinion to guide you. Are you on the right path? Or is it a chance or an opportunity for you to explore different regions to confirm if the care that you're receiving back home, is that the treatment that you should be seeking? Or could there be a gap that your local doctor has not been able to identify? So through the second medical opinion channel, we get the medical results reports existing, and we get to share that with doctors. What we do is we get to match based on destination, the treatment option that this patient requires, and also in terms of affordability. So you will find within the African space, we have a great chunk that goes to India. However, we still have a team that might opt, or rather a segment of people that might opt for treatment within various destinations such as Turkey, UAE, the European market, based on their affordability, or also in terms of the knowledge that we'll be able to share with them on where would this treatment be affordable for them. So once those information is shared with us, something else that Mwanza and Dr. Salome also mentioned is the aspect that within the African space, most hospitals will do the diagnosis, especially those within the public sector, but they hardly get to share these results with patients. So once a patient is now in a space of uncertainty, they do not have any medical records to share. And that's also another advantage that the second medical opinion offers to these patients, where we acknowledge the gap of the lack of medical reports. However, the doctor that you would be able to connect with overseas, from the summary that a patient is able to provide or the family is able to provide, they can narrow down and highlight what test would you be in a position to do locally share those tests with them, and from there then they can make an informed decision, or they can do a deduction in terms of this is the path that we would want to explore. Secondly is when we share those medical reports with hospitals, they also do their own clinical assessment on, I could send in medical reports from the aspect of I feel or rather have seen an orthopedic surgeon, and he is leaning more onto a spine issue, only for the doctor overseas to assess and highlight that no, this is not something to do with spine, but could be leaning more onto an oncology case. So they bring in different doctors to assess those medical reports and advise on who would be the ideal doctor to see to be able to give a proper diagnosis. From the point where the patient has done the second medical opinion and has confirmed that they're wishing, or rather they're in a position to travel overseas for continuity of care, there is also the second gap that's experienced in terms of coordination. There is no one to guide you through on which hospital would be ideal for your condition. How do you commence the process of getting what's required for you to travel overseas? Which country would be easier for you to access based on your nationality? How much would it cost for you traveling overseas in terms of the accommodation, the treatment, and the meals? And that's where my One Health team comes in place, being able to handhold and walk the entire journey with you, ensuring that you're not walking alone and the family feels completely supported, ensuring that from the word go, you have all the information that you need, what would be the cost estimate of the treatment, assisting you get accommodation options, assisting you in terms of the visa process, assisting you with also flights, and also confirming how much would you require when it comes to meals, and ensuring that you're going to a land that's unknown to you and also to the family that would be traveling with you, but having someone on the ground who is there to support you through the entire journey and process. And it's not just in terms of the coordination aspect, but emotionally supporting you through the entire journey. Some people travel when there is no clear diagnosis, only for them to get to the hospital. And now with the clear diagnosis, the family and the patient is taken aback. It's overwhelming even for the caregivers, not knowing where to begin and what the next steps would be. So the team is empowered and well conversant in terms of supporting people emotionally during that entire process, ensuring that you're not feeling alone, but giving you the guidance that you need and being with you step by step through the entire journey. And once your treatment is completed, the other gap comes in with medical reports, ensuring that once you receive your care overseas, you have all the medical reports that are needed post your treatment, getting an opportunity, or rather based on a request, ensuring that the treating doctor overseas gets to connect with your local doctor so that the local doctor is well informed on this is the treatment that was offered to this patient. And in terms of next steps, we propose that you support them through this so that once you return locally, despite whatever treatment or rather treatment that you received, there is that clear guidance on this is how you need to proceed. Because something else that Mwanza captured when she began was the aspect of having a few hematological specialists within the African space. So you will find someone comes back to their country and that gap remains open. But through the interaction that some of these hospitals have had with the African doctors, some of the hospitals may even direct you on which doctor are you supposed to see once you get back home. So it's sort of, you're given a clear path and extra support also from the hospital. There's also the continuous connection with the doctors overseas, and this is done through virtual consultations where the constant reviews are done to also confirm that you're on the right path. And in case of any challenge that's experienced with your with post-treatment care, also that support is there so that one does not go back to the space of you're sort of making a good recovery, but upon returning home, then there are challenges that are faced and one is not sure how to navigate. So the contacts of the doctors and the hospitals will be there to ensure that you can quickly get them on call to be able to support you through the process. How we've done this is by building a very strong hospital network. We currently work with more than 350 hospitals and clinics within our network within 21 countries. Just to mention a few, we have partnerships with leading hospitals in India, Turkey, UK, Thailand, UAE, Singapore, South Korea, Egypt, Malaysia, Kenya, just to mention a few. And the doctors or hospitals that we work with are those within the specialized healthcare department or in terms of treatment options. And most of the hospitals are multi-speciality, being able to address even patients who are going through issues of comorbidity. As Mwanza mentioned, when patients are diagnosed with sickle cell, there are other organs within their body that are affected. So you will find one is going in for oncology care, but in the process, the ailment or condition has affected their kidney, has affected their organs. So there is also doctors from different specialties that are able to step in and support the patient through their treatment journey. And it's not sort of, it doesn't simply focus on oncology. So then there is a gap for those that have issues with comorbidity. And how we get to do this is through our vetting process. We are very comprehensive to ensure that we do a very comprehensive and due diligence with the hospitals that we work with. And this is pegged on different aspects such as accreditation, their success rates, their patient experience, which tends to, we are moving in a space where patient experience is very important. We know doctors may struggle in terms of being able to communicate to patients, but patient experience is very important. It's not just the aspect of treatment for the patient, but how is the patient being supported? Not just the patient, but also the family members. How are they being supported through their treatment journey at the hospital? Once they get there, is there anyone who is hand-holding you? It's moving from your own country, from your own comfort zone to a space where you do not know anyone, and hence you need that extra support for people to guide you. Also look at the aspect of medical technology, what technology is present. We are also advancing within the African space where we are working on the medical technology that we have within our space, but we still aren't there. So we have also to match up the needs of, if we're looking at the African market in this case, what are the treatment options that are not available and what's available overseas to be able to help different patients. And one of them we could highlight is proton therapy and CAR-T cell, which currently we do not have any facility within the African space that's offering that. But this is a treatment option that's available that's saving lives out there. So we get to highlight, or rather do our research on what new treatments are available, which hospitals are offering these, and that helps us also to match up with patients on the required treatments and also advancing with them through the process. We also look at different markets in terms of what the requirements are. So getting away from the oncology part, we will look at it when it comes to organ transplant, which is also one of the challenges that we're currently seeing within the African market when it comes to treatment. So, for example, if one is going to India, they require a first-degree donor, and probably within your family, you do not have anyone who is a match. So we're able to assist through different destinations like Turkey, where they allow second up to the fourth degree relatives. So that means a cousin or an uncle could be in a position to step in as a donor and support that family member. So that sort of maps out the entire patient journey and the different support we get to offer the patients through their entire journey. Also in terms of culture, getting just to understand that much, or rather once you're in that country, how do you get that support? And that could also narrow down to the meals that we take. So you will find some people travel overseas and there is that challenge when it comes to the meals that they receive there. It's also in terms of communication, where this is the language you speak, but there is no one speaking that language. So through the hospitals, we are able to offer interpretation services to ensure that one feels comfortable to be able to express their condition and also get responses and support in the same. And also the aspect of culture, which could narrow down to meals. Within the African space, I believe we can all relate to one of the main common meals, which is ugali, and can be referenced to as fufu within different countries. So you find that's what you're used to, but then you get to the Indian space where they're eating different meals, might be spicy, and you can't manage what they're providing. The cultural support ensures that you're able to find meals that are comfortable for you, and also someone being able to understand this is how we do it, or rather, this is how I would prefer to be addressed. And that could also go down to the nitty-gritties of some countries will refer to you based on your surname, and probably if no surname is available, they kind of make you feel that you do not belong. But that understanding of cultural aspect, they will refer to you using what you feel comfortable with. So from me, that's it. And I'm grateful for this opportunity and the partnership that we have with AfriPharm to be able to support people within the African space to access specialized healthcare services without having to wait, and being the pillars or the voices of people within our own community, sharing this knowledge with them and helping us to bridge that gap. Thank you.
Eve, wow, thank you so much. I believe we laid the foundation with Mwanza and then Dr. Salome, and Andrew and Eve have basically shown you the pathways. We want to switch up the energy in the room as we're about to end soon. And at this point, I'd like to invite our local leadership. This is our agency director from Ghana, Zambia, and South Africa, Solomon, Elizabeth, Tuli. All right, so guys, take it away as we wind down. Please, it's the boys in your court.
Greetings, everybody. I hope everyone is well. That's good. Okay, thank you to all our speakers. We have heard what happens to patients, the real challenges that they face, and how My One Health steps in to bring world-class treatment within reach. If this is a story of heroes, then think of us collectively as the Avengers team of healthcare, because AfriPharm Health has a few heroic stunts of its own in this mix.
A few? She's being modest.
I'm being strategic, Solomon. So let me start where it begins for the patient. Now, when an AfriPharm Health member discovers that the treatment they need is not available in their own country, they go to the AfriPharm Health Global Care page and initiate a referral journey themselves. So it's in their hands, from their phone, and in their own time.
And if I may jump in, because that is not fully half of it, they do not have to do it alone. We can initiate the journey for them. A patient can quietly, literally shout, "Hey, Tuli," and it is on. From that moment, the patient's journey begins. She's not exaggerating, by the way. Tuli's phone does not sleep.
It does not, and neither does the system. My One Health matches the patient to the right treating hospital based on their condition and the specialist they need. And then here is one of those heroic stunts I mentioned. AfriPharm Health triggers a virtual call through the virtual care network, connecting the patient directly with the treating doctor at the hospital abroad before they have even left their home country. So the patient is then updated through every stage, and nobody is left wondering what happens next.
And that is already the difference. Most healthcare systems give you direction and then announce you have arrived at your destination while you are standing in an open field.
No, right? With no signal, hey?
With no signal and no pharmacy in sight. AfriPharm Health is the GPS that knows the road. It does not just point you in a direction, it walks you with the entire way.
Yes, Solomon. And it's worth being clear about what that GPS actually is, because AfriPharm Health gets misunderstood a lot. So it's not an app, it's not one service, it is one connected infrastructure made up of 5 networks working as a single system.
Yes, 5. Not one nice logo, at 5 actual networks.
That's correct. So we have the virtual care network that handles remote consultations and is the clinical front door. We also have the Hospital Partner Network, which provides advanced and critical care. The Emergency Partner Network coordinates real-time emergency responses. You have your ambulances, your first responders, and everything is geo-linked to the dispatch. And the Pharmacy Partner Network manages medication access and fulfillment. And the Home Care Network, I love, because it delivers care directly to the patient once they are back home.
And before anyone asks, no, these are not 5 separate apps pretending to know each other at a conference. They are interconnected, one patient, one journey, one continuous pathway, no gaps. No, that is not our department.
And you know what? That is not a department, should be banned from African healthcare entirely. Luckily, we are working on it. And at every step of that journey, the health vault is traveling with the patient. Every consultation, every prescription, every lab result, and every scan. There's just one record that travels with the patient instead of the patient chasing their own history across 12 different facilities.
Which in my market replaces the current system. A brown envelope and a folder somebody saved as new folder final version 3. Wow.
I know, right? That's not just in your country. I think that's the whole continent.
Version 3 was not even the final version, truly.
I know, right? And the health vault is not just storage. It is intelligent. The smart prescription engine sits inside it. It verifies medication safety, checks for drug interactions. It suggests generic alternatives where they exist. So when a doctor prescribes something, the system is already making sure it does not conflict with what the patient is already taking.
Which, if you have ever seen a patient arrive at a pharmacy with 3 prescriptions from 3 doctors who never spoke to each other, you know how important that is.
I do, right? And you know what? When that patient travels abroad for specialist care, the health vault is already packed. It has the health passport, which gives the receiving hospital a complete travel-ready clinical profile, a QR code accessible, emergency-ready. And by the time the receiving hospital takes on the patient, the full history is already in front of them. So nobody arrives as a stranger and nobody starts from zero. That is very cool.
Yeah, and that is the partnership working. The health vault and the health passport make sure the patient is known before they land. My One Health coordinates the treatment and then the patient comes home. And this is where everyone else quietly drops the patient and hopes nobody asks questions.
Thankfully, we're here and we asked those questions and we solved it already. So you see the patient lands and the home care network is already activated. Nurses, home diagnostics, your chronic care, everything is coordinated on the ground. The pharmacy partner network keeps the medication flowing, so the patient is not standing at a counter being told, we do not stock that, and to try another pharmacy.
I think you should think of it like an African mother's kitchen. Nobody leaves without being fed. Nobody leaves without being checked on. And if you try to leave too early, she will definitely find you.
That's true. So that's the home care network. You're not going anywhere until we are satisfied that you are recovering properly. And that's the most accurate description of our home care network anyone has ever given, actually, Solomon.
Yeah. And Dr. Chefo is the mother's assistant. It always stays with the patient through every step of recovery, checking in, tracking adherence, answering the questions at midnight that nobody else is awake to answer. The friendliest employee we have ever hired, never tired, never moody, works offline, which is in half the communities we serve. It is not a luxury. It is the only option. Unlike some people on this call, Dr. Chefo replies to messages immediately.
I'm choosing peace today, Solomon. Is it because I left you on red last Tuesday?
Thank you, Tuli. Noted and appreciated.
My apologies. So the last piece that we have is the one that people always forget until it goes wrong. That's payments. Unless the five network, underneath those five networks, rather, sits one cross-border payment rail. We have mobile money, bank transfers, diaspora remittances, and real-time forex conversion, all connected. So a daughter in London can pay for her mother's consultation in Lusaka, the medication in Dola, and the home care nurse in Kitwe. 3 services in 3 towns, and 1 payment is received instantly.
And the providers get paid. That matters. Escrow-based settlement means pharmacy, the nurse, the hospital, they are not chasing invoices. The trust is built into the rail, which is why it actually works on the ground. You can build the most beautiful system in the world, but if the money does not move, nothing else does either.
Correct. And that's the full picture, really. 5 interconnected networks with a patient-controlled health vault and the smart prescription engine inside it. A travel-ready health passport, Dr. Cheerful, the mother's assistant who never sleeps, and a cross-border payment system with escrow settlement underneath all of it, working together as one living infrastructure.
And it is the same infrastructure in every one of our markets. Ghana moves fastest, obviously, over 17% insurance growth a year, while the rest of you are still indicating to change lanes.
Oh, goodness, brace yourselves. We're coming for you.
Well, Ghana has already arrived, packed, and we just ordered for some Ghanaian jollof, you know.
You've been holding that line since the agreement was signed. But anyway, while you eat Ghana, speaking on a perspective from Zambia, this is where we see where it actually matters. We all met the Zambian market at the start of the session. Mwanza, the sickle cell, a caregiver, a mother, well, a Zambian. To the other countries, it's a powerful opening. But to Zambia, that is a neighbor of a Zambian resident. And I'm sure Zambians have also watched families send someone they love abroad for treatment and watched it all fall apart when they came home because nobody was waiting. The grid is what is waiting for them now. And that's the good thing.
Yeah. So 3 markets, 3 completely different realities, but the same 5 networks, the same health vault, the same smart prescription engine, the same Dr. Cheerful, the same payment rail. So the patient does not have to chase 4 different systems.
Correct. They get one grid that opens up in 4 places and different doors.
Yes, the same grid, and that is AfriPharm.
Correct. AfriPharm.
Thank you.
Thank you so much.
Guys, I love that banter. Well, to everybody in the room, that's our AfriPharm Health local leadership from Ghana, South Africa. Elizabeth had some technical challenges, but I think these guys presented what needed to be presented. We're saving the last but not the least. I'd like to introduce someone who basically is in charge of our entire strategic dimension in terms of our financial vision. What you heard is what the Africa's health grid in practice looks like. It's not a product roadmap. It's not a pitch either. It's an operational system. It is live today across the markets that the guys just mentioned. It's taken us 3 years to get to where we are today. It is a product envisioned, developed, and brought about in this African market and environment. So it's cultural sensitive in terms of, where you are. And I'm glad to say that, with our partnership with My One Health, what we'd like to do is take this African culture in terms of what we can do for our patients across their 6 continents. As we come to a close, I'd like to introduce to you, obviously, the person who's in charge of our financial and Pan-African strategy dimension of everything you've just heard and everything I've just described. I want to bring in person the person who holds the financial architecture, obviously, but drives the strategy of how we do all these cross-border payment rails, the investor narrative, and the financial narrative in terms of how we scale. We don't obviously believe that, a product should be one that answers to a foreign intervention. We believe all the strategies lay here in Africa. Please help me welcome our managing partner and our group CFO, Lucy, as we call her affectionately, Zara. Please, Zara, close up, take the ball.
All right, thank you. Good afternoon, everyone, and thank you to all the speakers. Thank you to Tuli, Solomon, and Elizabeth for that amazing banter. I have to be honest with you, every time I hear that story about Mwanza, I feel it, because that's not a case study. That's a real woman, a real family, a real moment of crisis where everything depended on what was waiting on the other side. So the question is anything waiting for them? That is patients coming back home. That is one of our whole infrastructure. That's what our whole infrastructure was designed to answer. Sorry about that. It's not marketing, but that's actually the mission. And that's exactly why we do this work from here, from the UK, personally myself, because the families funding that care, many of them are here in the UK, in Europe, or anywhere else in the world. They're sending money home every month for school fees, for living costs, and yes, for medical bills. They can barely understand because they weren't in the room when the diagnosis was given. AfriPharm Health exists to change that, to make sure the person in London isn't just sending money into a void. They're connected to a care pathway. They know what's happening. They can contribute meaningfully to a recovery that is actually being coordinated. That's the human case. And the human case is the commercial case. As you heard, Andrew and Eve showed you the referral out. That's the specialist care, the coordination. That half is built beautifully. But now it's the return, which is the follow-up, the pharmacy, the home care, the family member here who needs to know their mother is being looked after. That half has always been left to chance. Not anymore, not with AfriPharm. So what My One Health and AfriPharm Health are building together is a care corridor that doesn't abandon the patient at the airport. It follows them through. It brings them home, and it keeps them well once they get there. When you build infrastructure that genuinely serves the patient, that keeps the record connected, that brings them home to care that's waiting, you build something insurers want to back, employers want to offer, and international partners want to be a part of. South Africa being the anchor, Ghana, like Solomon said, moving fast, Zambia carrying the heart of why this matters. And the UK, where I am, that's the bridge to insurers, institutional partners, diaspora communities, and the investors ready to back something solving the right problem. My role from here in the UK is to make sure the world sees that, and that the capital, the partnerships, and the credibility that this infrastructure deserves actually reach it. So this is what we believe in. Capital follows care. That is our position as AfriPharm. Today you have seen from patient story to clinical pathway to ground infrastructure exactly what that means in practice. One grid, the patient at the center, and that's the most important thing all the way home. So I want to thank everyone that's been on this podcast, all the speakers and all the listeners. Thank you so much, and have a wonderful day.
So as we end, I'd like to pose a question to the panelists here. This is the part where we have a Q&A in terms of if you can write to us. But I'd like to first of all thank Lucy and thank you all for the voices that have been in the room. Manza, for the truth that no statistic can carry. We can't even begin to envision exactly what you go through day to day, but the heart that you've shown in terms of where you're just not a number, the truth actually carries out a bigger outlook in a community. Dr. Salome, for the clinical honesty and the system that the system needed to hear, and just basically what the room needed to be guided on. I thank you for taking the opportunity. Andrew and Eve, for the infrastructure that connects our patients to 350 hospitals across 6 continents, and obviously, I like the way you put it, Andrew. I don't know what I would have done before all of this, but I'm glad we're partners now. And to the guys, the clowns in the room in the circus, Solomon, Tuli, and of course Elizabeth Watt, very difficulties connecting. Well, I just want to thank everybody. The missing link is no longer missing. The infrastructure exists, the journey is complete, outbound and inbound, to every patient, every caregiver, every clinician, every medical aid scheme, and every institution in this room. Don't wait. The path is open, the records travel with you, the infrastructure is waiting for you. But I'd like to pose a question as we end. If a patient in your community received this call today, a confirmed referral pathway, a verified specialist match abroad, a health support that travels with them, and a home care network waiting when they landed, what is the one thing that would still stop them from saying yes? Because the answer tells exactly what we still need to build and exactly what we need to say to every patient who's still waiting, where they are or whether they're getting better or not. But with that statement, I just want to say thank you to everybody. It's taken us 3 years to get to this point. For builders like Tony, who's in the room, thank you for coming. They'll understand and they'll tell you that Africa is a place where you build solutions that basically go out to the market and make a difference in people's lives. Thank you all. If you'd like to write to us, you can write to us. Our email address is info@afrifarmhealth.com, or you can visit our website, afrifarmhealth.com, and you can actually get a preview of our solution. The link is actually there. I'd like to take the opportunity again just to thank you, and please have a blessed afternoon. We'll see you next week for another exciting conversation as we build onto Africa. Thank you. you.